Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 289 of our pharmacotherapy series, which majors in thrombosis. The first question reads, AVG, who has been taking Warfarin for 3 years with good INR control, noted bright red blood after a bowel movement, hematochezia, that resolved and has not returned. In the emergency department, an INR of 5.6 was reported. Her hematocrit and hemoglobin were both within normal limits, as were her vital signs. A stool GWAG test was positive, and multiple external hemorrhoids were detected. So my question to you is, how should this adverse effect of warfarin be treated in AVG? Management of over-anticoagulation depends on the clinical presentation of the patient. In the case of an elevated INR without bleeding complications, interruption of warfarin therapy by holding 1 or 2 doses until the INR returns to the therapeutic range is usually sufficient. Minor bleeding complications accompanied by an elevated INR can also be managed by withholding warfarin therapy for a short period until bleeding resolves. In either case, the patient should be questioned to determine a possible cause for over-anticoagulation, including intake of extra doses of warfarin, changes in diet or alcohol intake, changes in underlying medical conditions, or the use of other medications. In some cases, no apparent explanation is identified. Depending on the cause, a reduction in the maintenance dosing of warfarin may be necessary. The time required for INR to return to the therapeutic range after warfarin is withheld depends on several patient characteristics. Advanced age, lower warfarin maintenance dose requirements, and higher INR are associated with increased time for INR correction. Other factors that can prolong the time for INR to return to the therapeutic range include decompensated heart failure, active malignancy, and recent use of medications known to potentiate warfarin. Although previously recommended and commonly used, low-dose vitamin K in patients with elevated INR 4.5 to 10 and not bleeding is not associated with a reduction in major bleeding, and is no longer routinely recommended. However, patients with INRs greater than 10 and not bleeding may benefit from small doses of oral vitamin K 1 to 2.5 mg. The decision on whether to give vitamin K in non-bleeding patients needs to consider the patient's individual risk for bleeding and thrombosis. An oral dose of 1 to 2.5 mg can correct over-anticoagulation in 24 to 48 hours without causing prolonged resistance to warfarin therapy, a problem commonly seen with larger, that is 10 mg, doses of vitamin K. Intramuscular administration is contraindicated due to the risk of hematoma formation, and subcutaneous administration of vitamin K is not recommended because of variable absorption. IV doses of 0.5 to 1 mg of vitamin K can correct over-anticoagulation within 24 hours. This approach is also useful for reversal of therapeutic anticoagulation before invasive procedures and can be used to correct over-anticoagulation in high-risk cases. Intravenous vitamin K should be diluted in a minimum of 50 ml intravenous fluid and administered with an infusion pump over a minimum of 20 minutes to prevent flushing, hypotension, and cardiovascular collapse. Although these symptoms resemble anaphylaxis, the mechanism of this adverse response is unclear. It is not known whether it is caused by phytonadione or by the vehicle in which phytonadione is formulated. If this adverse reaction occurs, administration of epinephrine may be indicated, as well as other standard measures to support blood pressure and maintain the airway. Rapid reversal of warfarin therapy is indicated in the setting of major, life-threatening bleeding, i.e., severe gastrointestinal bleeding, intracranial hemorrhage. Fresh frozen plasma or factor concentrates to replace clotting factors will decrease the INR for 4 to 6 hours and should be administered as needed with careful monitoring of volume status. Supplementation with high-dose IV vitamin K, that is 10 mg, may also be indicated. Administration of IV vitamin K will reverse the effects of warfarin within 6 to 12 hours. However, if continued warfarin therapy is indicated when bleeding resolves, anticoagulation with heparin may be necessary for as long as 7 to 14 days until the effect of high-dose vitamin K is diminished and warfarin responsiveness returns. Hematochezia may be an early sign of more serious bleeding, but in many cases this condition is associated with minor bleeding episodes and identifiable causes such as hemorrhoids. In a reliable patient, holding the warfarin until the INR returns to a therapeutic level usually suffices, along with the addition of a bowel regimen to prevent straining with bowel movements, topical cream to minimize swelling and irritation, increased fluids, and/or increased fiber intake. Because AVG appears to have only minor bleeding from the stool, is hemodynamically stable, and has a stable hemoglobin, withholding warfarin is appropriate. If the patient has never had a colonoscopy, then evaluation for the appropriateness of this test may be warranted. The next question reads, MPC, a 25-year-old woman, takes warfarin for chronic therapy for recurrent DVTs. She tells you today that she missed her menses and thinks she may be pregnant. A pregnancy test ordered today was positive. What effects might warfarin have on the fetus? Are unfractionated heparin or low molecular weight heparins safer alternatives in this situation? Warfarin and other coumarin anticoagulants cross the placental barrier and may place the fetus at risk for hemorrhage and teratogenic effects. Up to 30% of pregnancies that involve exposure to coumarin result in abnormal live-born infants, and up to 30% in spontaneous abortion or stillbirth. Congenital abnormalities such as stippled calcifications and nasal cartilage hypoplasia primarily occurred in infants born to mothers receiving warfarin during the first trimester of pregnancy, with the highest risk during weeks 6 to 12. Other abnormalities, involving the central nervous system and eyes, are more likely to occur when the mother is taking warfarin later in the pregnancy. In addition, because warfarin crosses the placenta, fatal bleeding complications may occur. Women of childbearing age who require anticoagulation should be counseled about options for contraception. Patients who become pregnant while receiving warfarin should be informed of the risks of continued anticoagulation to the fetus, as well as the risk to themselves of discontinuing anticoagulation. Other options for pregnant women who require anticoagulation include unfractionated heparin and low molecular weight heparins. Because these agents do not cross the placenta, they are preferred over warfarin for use in pregnancy. Many clinical trials have validated the safety and efficacy of unfractionated heparin and low molecular weight heparins in the prevention and treatment of deep vein thrombosis and pulmonary embolism during pregnancy, with low molecular weight heparin generally preferred to unfractionated heparin for long-term management throughout pregnancy. When used at full doses for the treatment of venous thromboembolism during pregnancy, dosing must be adjusted throughout the pregnancy to account for the expected increase in the body weight of the mother and the reported increase in clearance of low molecular weight heparin during pregnancy. After being informed of the risks associated with warfarin, MP decided to continue her pregnancy and to begin anticoagulation with low molecular weight heparin. Because pregnant women were excluded from clinical trials with the direct oral anticoagulants due to their increased risk for maternal and fetal bleeding, the use in pregnancy is not recommended at this time. Warfarin therapy should be discontinued immediately and low molecular weight heparin initiated using subcutaneous treatment doses as previously described. Dosing adjustments may be required throughout pregnancy based on changes in body weight and clearance, possibly guided by anti-factor Xa monitoring. Potential adverse effects of low molecular weight heparin use, including hemorrhage, thrombocytopenia, and osteoporosis, should be monitored appropriately. For women desiring spinal anesthesia during delivery, treatment doses of low molecular weight heparin should be discontinued a minimum of 24 hours before induction of labor, caesarean section, or placement of an epidural catheter, and restarted no sooner than 24 hours postoperatively, and with adequate hemostasis in place. Neuraxial anesthesia should not be used in anticoagulated women, i.e., within 24 hours of the last treatment dose of low molecular weight heparin, or for patients receiving IV unfractionated heparin that have prolonged activated partial thromboplastin times. In patients not receiving epidural catheters, postpartum anticoagulation may be started 12 to 24 hours after delivery as long as there are no bleeding concerns. Consider IV unfractionated heparin in women at high risk of bleeding, with low molecular weight heparin reasonable for most women. Restart warfarin when hemostasis has occurred, bridging with unfractionated heparin or low molecular weight heparin until the INR is therapeutic. Warfarin, low molecular weight heparin, and unfractionated heparin do not accumulate in breast milk and do not induce anticoagulant effect in the infant and may be used in women who breastfeed. Therefore, MPC can safely breastfeed. The direct oral anticoagulants are not currently recommended during breastfeeding. The next question reads, CTS, a 66-year-old woman with hypertension and no other significant past medical history, presents to the cardiology clinic complaining of several days of fatigue and a racing heart. On physical examination, her pulse is irregularly irregular, and her heart rate is approximately 120 beats per minute. Using ECG, a diagnosis of atrial fibrillation is made and cardioversion planned. Should CTS be anticoagulated before cardioversion? In atrial fibrillation, atrial activity and atrial enlargement cause stasis of blood within the atria and the left atrial appendage, which can result in atrial thrombus formation. Atrial thrombus formation increases the risk of systemic embolization. Clinical manifestations include arterial embolization of the extremities or embolization of the splenic, renal, or abdominal arteries. However, the most prevalent site of embolization is the cerebral arterial system, resulting in transient ischemic attack or stroke with potentially devastating neurologic and functional impairment. Atrial fibrillation carries a five-fold risk of ischemic stroke without thromboprophylaxis. Both direct current cardioversion and pharmacologic cardioversion using antiarrhythmic drugs expose patients to an initial short-term increase in stroke risk from embolization secondary to resumption of normal atrial mechanical activity cardiac arrhythmias. Data from a prospective cohort study of 437 patients noted a stroke incidence of 5.3% in patients with atrial fibrillation who were cardioverted without prior anticoagulation, but a significant reduction in stroke incidence to 0.8% was noted if patients who had received cardioversion were anticoagulated. In addition to preventing the development of new atrial thrombi, anticoagulation allows any thrombus that may be present to endothelialize and adhere to the atrial wall so that the thromboembolic risk is minimized. Based on the assumed time course of thrombus development, as well as the presumed time course of clot endothelialization, patients who have been in atrial fibrillation for 48 hours or longer should receive 3 weeks of therapeutic anticoagulation with warfarin to a target INR of 2.5 range 2 to 3 before cardioversion is attempted. Direct oral anticoagulants such as dabigatran, rivaroxaban, and apixaban are alternative options to warfarin therapy. Despite a lower risk of stroke than that associated with atrial fibrillation, patients with atrial flutter should be treated similarly. Whether CTS has been in atrial fibrillation for 48 hours is not known. Therefore, she requires a 3-week course of oral anticoagulation before cardioversion is attempted. If CTS cannot tolerate her heart symptoms despite control of the ventricular response rate, her medical team might consider immediate cardioversion without anticoagulation if transesophageal echocardiography, abbreviated as TEE, is used to rule out left atrial thrombi. Transesophageal echocardiography is much more sensitive than transthoracic echocardiography, abbreviated as TTE, to visualize the left atrium and the left atrial appendage. In a clinical trial, 1,222 patients with atrial fibrillation for a duration of 2 days or more were randomly assigned to either cardioversion guided by transesophageal echocardiography or to conventional anticoagulation prior to cardioversion. Patients assigned to conventional treatment and patients in the transesophageal echocardiography group in whom thrombus was detected received a 3-week course of warfarin before cardioversion. Patients without detectable thrombus by transesophageal echocardiography were cardioverted without prior anticoagulation. All patients received 4 weeks of post-cardioversion anticoagulation. Thromboembolic rates were identical between patients who received conventional treatment and those whose treatment was guided by transesophageal echocardiography, 0.5% versus 0.8%, with a p-value equal to 0.5. The next question reads, after 3 weeks of regular intensity warfarin therapy, CTS is successfully cardioverted to normal sinus rhythm. Should anticoagulation be discontinued? Despite normalization of atrial electrical activity, restoration of effective atrial mechanical activity after cardioversion of atrial fibrillation can be delayed for up to 3 weeks. In addition, many patients who are cardioverted successfully will revert to atrial fibrillation during the first month. These factors contribute to the recognized delay in stroke presentation after cardioversion in patients with atrial fibrillation. Therefore, anticoagulation should be continued after cardioversion for a minimum 4 weeks. Longer duration of anticoagulation therapy should be based on the individual patient's thromboembolic risk profile. 2 weeks after successful cardioversion, CTS presents to the emergency department with chest palpitations and lightheadedness. An ECG is performed and indicates atrial fibrillation again. What decisions regarding anticoagulation need to be made? Let's consider anticoagulation in valvular atrial fibrillation. Atrial fibrillation secondary to valvular heart disease has historically been recognized as a significant risk factor for stroke. Patients with atrial fibrillation who have a history of rheumatic mitral valve disease have a 17-fold higher incidence of stroke than in matched controls. Patients with valvular atrial fibrillation require long-term, regular-intensity anticoagulation with warfarin to a target INR of 2.5 in the range 2 to 3 to prevent thromboembolism and stroke. Direct oral anticoagulants have not been studied in this patient population and should be avoided at this time. Let's now discuss anticoagulation in nonvalvular atrial fibrillation. Nonvalvular heart disease is the most common cause of atrial fibrillation and, like valvular heart disease, represents a significant risk for stroke in patients with atrial fibrillation. 5 clinical trials have substantiated the role of warfarin in the primary prevention of systemic embolization and stroke in chronic, nonvalvular atrial fibrillation. All 5 trials compared warfarin with a placebo and were terminated before completion because of the substantial benefit of warfarin. In comparison with a placebo, warfarin significantly reduced the risk of stroke from approximately 5% per year to approximately 2% per year, with an average relative risk reduction of 67%. Based on the results of these trials, long-term anticoagulation with warfarin to a goal INR of 2.5 range, 2 to 3 is recommended in patients like CTS, who have atrial fibrillation secondary to nonvalvular heart disease. Several clinical trials have attempted to define the comparative efficacy of warfarin versus aspirin in the prevention of stroke associated with atrial fibrillation. Compared with a placebo or control, aspirin decreases the risk of stroke in patients with atrial fibrillation. However, that reduction is not as substantial as the reduction seen with warfarin. In clinical trials comparing warfarin and aspirin, the risk reduction associated with warfarin is significantly larger than that of aspirin. However, aspirin may be appropriate in certain patients at low risk for stroke associated with atrial fibrillation based on individualized risk assessment using the CHADS2 and CHA2DS2 VASC score. The CHADS2 score is currently endorsed by ACCP, whereas the CHA2DS2 VASC score is endorsed by the American Heart Association, American College of Cardiology, Heart Rhythm Society AHA, ACC, HRS, and the European Society of Cardiology ESC. Subsequent trials have confirmed the superiority of warfarin over the combination of aspirin plus clopidogrel for stroke prevention in atrial fibrillation, and the increased risk of intracranial hemorrhage when aspirin and clopidogrel are combined. Next we will look at direct oral anticoagulants. The direct thrombin inhibitor, that is dabigatran, and direct factor Xa inhibitors, such as rivaroxaban, apixaban, and edoxaban, have all been compared to warfarin for stroke prevention in patients with nonvalvular atrial fibrillation. Patient-specific characteristics such as age, renal function, weight, concomitant medications, and past medical history should be considered when selecting the most appropriate anticoagulant for initial therapy. Cost, insurance coverage and patient preference with regard to number of daily doses, frequency of monitoring, etc. must also be taken into account. The decision to continue long-term anticoagulation with warfarin in CTS should be based on an evaluation of the likelihood that her atrial fibrillation will become chronic with a paroxysmal, persistent, or permanent presentation, as well as an assessment of her risk of stroke compared with her risk of anticoagulant-associated bleeding complications. Because of her age and history of hypertension, CHADS2 score of 2 and CHA2DS2 VASC score of 3, the appropriate strategy should be long-term anticoagulation, either with warfarin at a goal INR of 2.5, in the range 2 to 3, or full-dose direct oral anticoagulant therapy. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it, and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 290.